So you know you have to first.
Yeah, I'm told to stand in the box. And to share my slides. I'm gonna get this set up first, and then, oops, actually. I'll get myself sharing, and I'll actually say something, I promise. Okay. I'm hoping folks can see slides. Oh, there they are. Perfect. Okay. I can't tell you how pleased I am to be here with you all tonight. I'm really honored for the invitation. Thank you, Holly. It's just always such a pleasure to come into a room of people and have a conversation about the work that we do and how that may apply to you and your families. I really prefer an informal type of event, but appreciate this is being recorded. So please, I hope you can take note of any questions or comments or thoughts you have while I'm going through the slides. And we have lots of time at the end to have more of a discussion around the things that I'll speak about tonight. I did have my own land acknowledgement. I did just want to spend a moment to talk about our provincial hereditary cancer program. So our staff live and work on the traditional, ancestral, and unceded territories of many nations, including the Coast Salish peoples, the Lekwungen-speaking people, and the Stolo people. And the reason that I like to put this here, I think sometimes you start to feel a bit performative, these land acknowledgements, but as a healthcare worker, we're really recognizing the Indigenous specific racism in healthcare. And to our program, we see really low rates of referrals for Indigenous families to the work that we do, which means there's inequitable access to things like cancer screening and prevention. So we always do ground ourselves here and as a reminder of the work that we have yet to do. So this might be a bit tiny for people in this big of a room. Online folks might see it a bit better, but I can walk us through it. It's essentially a family tree. So when people come to see us, we draw a picture like this, and it tells us who's had cancer in the family, who has not, what kinds of cancer are they, when were they diagnosed, and it starts to give us an idea of could there be something hereditary in this family, meaning could there be a risk factor being passed along that's causing a higher risk for cancer over a lifetime. So the sort of lowest down box with some color on it is James, and he was diagnosed with prostate cancer at 57, so pretty young, and is now living with metastatic disease at 59. If we go one generation up, his father had prostate cancer at 84, though died of unrelated heart issues at 91. His paternal uncle, Jim, lifetime smoker, had lung cancer recently. And then on his mom's side, there's an aunt there with a young ovarian cancer at 45. So these are the types of families we start to meet with where we see cancers at a little bit of a younger age. Prostate cancer and ovarian can be related to each other when they're hereditary. And we see both a son and a father with prostate cancer. So we have that question, is there a link here? And what can happen over time when we meet with families is, unfortunately, we can see a change or an update in the family history where now a few years later, James has died of his disease, his sister has had breast cancer, and his daughter has had breast cancer at 36. And now this is really starting to look like to us that this is a family with a potential hereditary risk. And our real sole purpose in what we do is to try to prevent these additional cancers in families. So if we meet with your family at a point in time, the idea is to prevent any additional cancers or to find them as early as we can if there's a hereditary risk. So we'll come back to this family at the end, but just to set the stage for the type of work that we do. So these slides are going to feel a little like biology class, but I like to kind of get us all on the same page in terms of basics here. No surprise to anyone in this room that prostate cancer is common. I'm sure you're tired of hearing that. So it's about 1 in 8 people born with a prostate that will develop cancer there over their lifetime, about 12.5% lifetime risk. And the biggest risk factor we know is still age. So most people are diagnosed over 50, like many cancers. There are some other risk factors I've listed here. So some things in the environment, that we don't know really a lot about environmental and lifestyle and what causes prostate cancer. Certain ethnic groups, so people who are Black have a higher risk of prostate cancer. And then really the focus of our talk today is people who have a family history do have a higher chance of developing prostate cancer. And we'll go into more detail about that. I feel like this is really tiny for you all. I apologize for that. So when we're talking about what causes cancer, this is a pie chart that we often show to people that we meet with, and next to that pie chart are little jars. And the idea is that if you have a jar, and that's your cancer risk for, let's say, prostate cancer, you might start off with an empty jar. And over your lifetime, you accumulate different risk factors or different genetic mutations, which often just happen by chance. They're just random events that can fill your jar. So about 75% of the time, we call it a sporadic cancer, where this jar is filled up with things in the environment. So things like age, maybe lifestyle, random events, but really not things that people are born with right from day one. And that's what all those little green dots are. We do see in some families that maybe there's a couple of people with prostate cancer. It looks like maybe there's a bit more of a risk than just by chance. And in those situations, I can see my pointer. Yeah. It could be a combination of factors. So these blue dots are inherited genetic factors that each give a little bit of risk, that have filled up some of the jar. And then we still need a lot of these kind of chance events to fill the jar and cause a cancer diagnosis. And in hereditary cancer, the real difference here that I hope you can appreciate is that people are born right from day one with one significant risk factor for the cancer they've developed. That's that big blue dot sitting there that's filled up, a quarter to a half of the jar right from birth. Cancer risks are not 100%. Even if you inherited a risk, you still need all these other factors. But the idea is that you're starting off right from day one with a higher chance than someone who is not born with that genetic risk factor. So this is my last sort of biology slide. So the pictures here, what they're intending to show is that genetic mutations happen all the time. They're common, they happen to all of us. And the real importance for cancer is, when do they happen? And the real importance for what does it mean for our families depends on when do these genetic mutations happen. So in the yellow here, this is the situation where there's a genetic mutation in a sperm or an egg cell. It's then present in every cell of that person's body, including some of their own eggs or sperm. So that's how it becomes hereditary, and it can be passed along in families. Another word for that is germline. In the purple here, this person was not born with any genetic mutations, but at some point over their lifetime, they've developed a mutation or a number of mutations in a specific tissue or cells in their body. So let's say the prostate. Those genetic mutations caused the cancer, but they're not in your eggs or sperms. They're not being passed on to the next generation. So all cancer is genetic in the sense that it's always caused by genetic mutations. Most is not hereditary and related to these mutations that can be passed on in families. This is where I wish I could pause for questions. Okay, so last little bit here about why do hereditary cancers, why is the risk higher? Why can we see it at younger ages? So if we have a sporadic cancer, again, happening by chance, this little bit on the top here is a cell. There's a gene in that cell that's protecting it from becoming a cancer. And we're born with 2 copies of all of our genes. So those are working just fine. It takes quite a number of years until a random genetic mutation knocks out one of those genes. You've still got your backup copy. And then over time, a second mutation happens. There's no longer a working copy of the gene. And that's when a cancer can develop. In hereditary cancer, every cell in the body starts off with one mutation or one gene that has a mutation in it, which is okay as long as that backup copy is there. But if we get one of those random mutations, there's no longer a working copy of the gene in that cell. And again, it can become a cancer. So you really just have to lose one copy and then you're on your way. And so that can lead to cancers happening more often in families, people being diagnosed with more than one cancer, and potentially at younger ages. So how is hereditary cancer passed on, or what's the risk for next generation? So if we have one of these gene mutations in the family, that's depicted by this purple person here, this person has one copy of this hereditary cancer gene that doesn't work, has the mutation, and one copy that works just fine. So every time they go on to have a child, it's either that copy with the mutation that's passed on, or the copy that works just fine. So it's really a 50-50 chance with every pregnancy. It's not sex or gender dependent. It's really just random, whether that's passed on or not. So it's 50%. Okay. I wanted to speak a little bit about metastatic prostate cancer. And the reason why I'm highlighting this is that while most prostate cancers, it's about a 5 to 10% chance it's hereditary. With metastatic prostate cancer, that goes up to about 12 to 17% chance. So it's more likely to be hereditary if someone has metastatic prostate cancer. And this big list of genes, or just all the different genes we can find with hereditary prostate cancer, and I've highlighted 3 of them here. They're called BRCA1, BRCA2, and ATM. And the reason for that is that what's happened recently is that if people with metastatic prostate cancer have a mutation in one of these genes, they're potentially eligible for more targeted treatment. So instead of just thinking about genetics and how does it impact the family, it can also now impact somebody's treatment based on whether or not they have one of these mutations. And that's whether or not they have a mutation in their germline, they've inherited it, or it's just in the tumor. It's one of those random somatic mutations. So for those who may be listening who have metastatic prostate cancer, your oncologist may have talked to you about things like PARP inhibitors or olaparib. It's really underscoring the reason why it can be important to have genetic testing both in your blood and in your tissue, your tumor, because it may give you better treatment options. Okay, so why do hereditary genetic testing? We get that question a lot. So we just talked about it can impact treatment. That's a newer reason to potentially think about it. It can tell us information about future cancer risks. So both for yourself as someone with prostate cancer, are there other cancers we should be looking out for more carefully? And then for your family, can it tell us more about who in your family may have a risk? What is the risk? What kind of cancer should we be looking for? Can we put in place extra screening? Can we put in place preventative tools so that we can alter that family history? So just for an example, this is the gene I just mentioned, BRCA2, which actually stands for breast cancer 2. It was found first in families with breast cancer. We've since learned it's not just breast cancer that people who have this gene mutation are at risk for. So in this graph, the bottom bar, or the lighter blue bar, is the general population risk for these cancers. So you'll see female breast and prostate are very similar, about 12.5% over a lifetime, with ovarian and pancreatic and male breast cancer being less common. If someone inherits a mutation in BRCA2 and they're female, their lifetime risk of breast cancer comes up to about 70%. There's an increased risk of ovarian cancer to about 15%. 40% risk of prostate cancer, and much more likely to be aggressive or metastatic. And then you'll see the same theme here, increased risk for pancreas and male breast cancer. So, prostate cancer may be where a family comes to attention, but we can sometimes uncover these other risks that can be really important for the family to understand. And this is just one gene. There's lots that we test, but that's an example. So what do we do with that information? So we're telling people you have this higher risk. How do we help? So for males who are at higher risk for prostate and breast cancer, we're starting PSA tests and digital rectal exams from 40, so a bit younger than you would if you didn't have this risk. And then chest wall exams on an annual basis. Oops. And for females, then we start breast cancer screening quite a bit younger. So from the age of 25 with breast MRI, adding in mammograms at 30, and then some people actually consider having risk-reducing mastectomies to remove their breasts to prevent that risk. We don't have good screening for ovarian cancer, and so that's also recommended to consider surgery to remove ovaries and tubes. And then we consider pancreas screening if there's a family history of that condition. So really identifying the risk is more than just saying you have a higher risk. It's really, what are we going to do about it now? Now, this I think might be something that's of potentially more relevance to more people in the room, thankfully with hereditary cancer being rare, but this idea of familial prostate cancer. So we're not looking at these high-risk genes that are coming along with other types of cancer risk. We're thinking about what does it mean to have a grandfather, a father, a brother with prostate cancer? What does that do to risk for other people in the family with prostates? So these numbers are interesting to think about because often if someone has a family history of prostate cancer, they'll go for more screening. So sometimes we feel like people may be diagnosed with something that would have been asymptomatic, but people are getting screening because they have a family history. So it may make it look like it's a bit of a higher risk than it actually is to get a symptomatic cancer. Regardless, what we see is if someone has what's called a second-degree relative with prostate cancer, so that's like an uncle or a grandparent, they have about twice the background risk to develop prostate cancer. So we started talking about that risk as about 12.5% or 1 in 8 people. So this could potentially bring that up to somewhere like a 24% risk. 24? Yeah, we'll go with that. If you have a first-degree relative over the age of 60, so that's like your father, a child, a sibling, that increases to about 3 times the risk. And then if you have relatives with metastatic disease, multiple relatives under 60 or Black ancestry, it's about 4 times the risk, which is really kind of getting up into some of those hereditary type risk categories. So really all that's discussed at this point is just the awareness of family history and the importance of prostate cancer screening, continued efforts to try to advocate for funded screening for prostate cancer, but this would start at the age of 40 to 45 and repeat every 1 to 2 years or based on PSA results. So in these families, we would do genetic testing and it's likely to come back negative. We wouldn't find anything because it's not those high-risk genes that come along with all those different cancer risks. But we should still pay attention to the history and make sure that people are aware of the screening option that's there. So I'm going to move on from that and just tell you a little bit about our program and what we do and what's available. So this is the tagline that we reduce the morbidity and mortality from hereditary cancer syndromes. That's our goal. But really, what does that mean? How do we do that? So we try to find people with hereditary cancer, provide them with risk management advice. Increasingly so are helping with some degree of cancer treatment decisions. We're certainly not, your oncology care team, but we can help talk about how your genetics may influence treatment. And then, excuse me, being a genetic counselor, the counseling piece really comes in terms of identifying resources, supports for families who are hearing this information. How do I tell my family? How do I work through this? Excuse me. That's kind of the counseling piece of what we do along with advocacy. So as mentioned before, we're a provincial program, but we have staff on site at the 3 BC Cancer Centres in Vancouver, in Abbotsford, and here in Victoria. We do most of our appointments actually on the phone or by Zoom, so you can come in person if you like, but we also don't need people to travel. So if you want to be in your own home when you're having conversations with people like me, you can do that from your home. And to simplify it a bit, the questions we try to answer for people with cancer are, why did I get this cancer? Will I get another cancer in the future? Is there a higher chance for my family to get cancer? Is there more cancer screening that can be done in my family to find cancer early? And is there a way to prevent cancer in my family? I'd say those are the most common questions we try to answer. So how do people get more information and access to genetic testing, which is usually a blood test? So for people who meet our criteria, and I'll talk a little bit in a minute about what those are, they can be referred to our hereditary cancer program. And at that point, you can either complete what we call our online patient portal. So you go online, fill out some questionnaires, watch a video, and you can actually print off a requisition for genetic testing from there and go to the lab and get it done. For those wanting to have a bit of a conversation before they go through that process, then there'd be the option of an appointment with a genetic counselor like myself or one of our physicians. For some patients, especially those with metastatic disease, their oncology care team, like your oncologist, may order genetic testing as part of just planning your treatment, with your consent, of course. We've called that mainstreaming genetic counseling or genetic testing, which was coined by a group in the UK who really wanted to bring genetic testing into the mainstream and kind of make it more available to people. If your oncologist orders the test and you have a positive result, meaning they found something, then you're automatically referred into our program so we can give you more information about what that means for you and your family. So for those online, I think it would be hard in this room. There are some QR codes on here. If you're QR code type folks, you could take a picture with your phone, and all that does is really link you out to our website. But I wanted to make a note that we do have referral criteria, like many services, because we try to focus our resources and what we do on families that are more likely to have hereditary cancer. We do have quite a high demand for what we do, so there is a related wait list, but we are doing a few things to reduce that. The note before about waiting for appointments. Well, that's a very hard part of this. Any healthcare provider or you yourself could refer yourself to our program. And if people don't know their family history well, which is very common for many different reasons, we can often still meet with them. So I wanted to just highlight some specific cancer criteria we're working on to expand, but currently we primarily meet with people who have metastatic prostate cancer, if they have close relatives with prostate cancer under 60, if they have a relative with prostate cancer, and there's some of those additional cancers that I mentioned before, like breast or ovarian or pancreas cancer in the family, or if someone's Ashkenazi Jewish and they have a history of prostate cancer in their family. That's a criteria in and of itself. The piece that we're still working on is if there's just a family history of prostate cancer, everyone's over 60. Right now, we need 3 people with prostate cancer to do the genetic testing. And that's usually because if you don't have that, it's very unlikely we're going to find anything on the blood test, which should be some good news. Yeah. Just a quick comment here in case anyone listening is of Ashkenazi Jewish descent. The reason why that's a criteria is that Jewish folks have about a 1 in 40 chance of having one of these higher risk gene mutations, whereas everybody who's not Jewish, it's about 1 in 250 people. So it is quite a difference in terms of the likelihood that we would find something in an Ashkenazi Jewish family. I did want to mention, we get this question a lot. People who aren't eligible for our program or they don't want to wait say, well, can I just pay to have this test done? And you absolutely can. The labs that are offering this testing are all in the United States. There's no private pay lab for this in Canada. It used to be about $5,000 to pay for this test, and now it's $300 US. So it has come down in price. It's still not insignificant, but it is approachable for some. And the important piece there is just to make sure you're picking the right lab. There's lots of labs out there that will say they can do this test and they're not accredited and they're not appropriate. So one that we use that's listed here is called Invitae. I'm giving you my contact information at the end. If you want more info on this, I can give it. But an important piece there is that if you and your family decide to privately pay for testing and they do find something, you're more than welcome to say, hey, I had testing, they found something, can you take it from here? And then we can still be involved in terms of what it means for you and your family and offer publicly funded testing to your relatives. Some of the considerations we have around genetic testing, I'll be curious to hear how people feel about it. Is that there can be some benefits and there can be some potential harms and different pieces to think about before undertaking it. So some people say that it really can help them understand what happened in their family. Why is there cancer here? Can help them learn of other cancer risks, what screening and prevention makes sense. The information might inform their current care or their treatment options. And it can help your family. It can really give them options to know and to do something about it. On the flip side, obviously this can increase worry and anxiety for people. Cancer in and of itself already does that. And so this feels like it's adding another layer on top of that. We do tend to see over time that initial anxiety or worry does tend to lessen over time as people get involved in screening and prevention and feel like they actually have a sense of control now over their future. Strained family relationships is an important one. People have different ideas about whether or not this kind of information is useful. I've had some people say that they're incredibly grateful that someone in their family had this test and gave them the information that they could use in their own healthcare. And then we certainly hear of situations where people are quite resentful that someone had this test and figured out there was hereditary risk in the family and really didn't appreciate that piece. So families are complicated and each one is unique, that's for sure. So I wanted to come back to this family that we saw at the beginning and how genetic testing may change things. And I've certainly seen this myself over the years that I've been working with families. So if we look at James here, so I know you can't read those tiny numbers, but essentially he has metastatic disease. He's now been put on a olaparib, and that's being used to manage his disease. We have a BRCA2 mutation in this family that allowed other people in the family to have genetic testing. Daughter Alice tested positive for this mutation and decided to go ahead and have a bilateral mastectomy and prevented her disease. The other daughter's not sure if she really wants to know about her genetic test result yet, but she can still enroll in screening until she's ready to know whether or not she's actually at risk. The sister of James found out about her genetic test result, had increased breast screening through MRI, and was found to have an earlier stage disease than if she would have presented with a mass as she did in the first example. This mutation was passed on to her son, who can now have increased prostate and male breast cancer screening. When his daughters are adults, they can consent to their own testing. The good news, there's always good news in every family, that her daughter did not inherit this mutation, so does not have an increased cancer risk and can just follow general population guidelines. Brother Paul also did not inherit the mutation, so that clears himself and his daughter and his grandson. There is still the question of their father, who had prostate cancer, which in and of itself could increase risk for Paul. We don't know yet which side of the family this mutation came from, but additional testing is done for James's mother, Jacinda, and she tested positive. She's living at 89 with no cancer. That does still happen in these families. Cancer risk is not 100%, and clarifies that Paul should still have some degree of increased prostate screening because his father had prostate cancer. And then another negative result over here in James's uncle. So details don't matter so much, but just to really show you that cascading effect of how this result can really be shared through a family and help clarify who needs what and who's at risk and who is not. So a bit of a summary, 5 to 10% of all prostate cancer and 12 to 17% of metastatic prostate cancers are hereditary. Genetic test results can help with treatment decisions and clarifying future cancer risk for a patient and their family. And some patients with prostate cancer can get publicly funded testing through either that mainstreaming pathway, which is through your oncologist, or through referral to our program. And I'll end there and just leave our contact information. So that's our email, our phone number, our website, and then that's my personal email at the bottom, which I can share if it's not clear for those in the room here, if you want to follow up at any time in the future. Yeah, thanks very much.